I'm Thomas Baldrick at ATS in Denver. The man next to me is kind enough to host us here. He is Dr. Aryeh Fischer, Associate Professor of Medicine in the Division of Rheumatology at National Jewish Health and the University of Colorado, based here in Denver. Thanks for taking a couple minutes with us.
Thank you.
So you presented a poster on the clinical features and natural history of autoimmune ILD versus idiopathic pulmonary fibrosis. What can you tell us about this poster and what your findings were?
Sure. So my fellow deserves a lot of the credit. She's the one who really did a lot of the work. Sandra Chartrand, a rheumatology fellow who spent some time with me. And what we wanted to do was to look at a group of patients who had an autoimmune feel to their interstitial lung disease, an autoimmune interstitial lung disease that did not fit existing classification criteria for CTD-ILD. Compare that group to defined forms of CTD-ILD and also to compare that group to idiopathic pulmonary fibrosis. So we really had three groups of patients that we looked at. Those patients who we know have a connective tissue disease related ILD, those patients that we know have an idiopathic pulmonary fibrosis, and then the third group of most interest to us were those patients who kind of fall between those categories. They have an interstitial pneumonia, an autoimmune feel to them, and we based our retrospective assessment on making sure that those patients fulfilled the existing classification schemes. They are defined as autoimmune interstitial lung disease either by meeting criteria for undifferentiated connective tissue disease, ILD, autoimmune featured ILD, lung dominant connective tissue disease, and interestingly, the cohort looks like they fulfill criteria for interstitial pneumonia with autoimmune features. And what we wanted to know was, does it matter? Does finding these autoimmune features and identifying patients that way, does it impact natural history, longitudinal pulmonary physiology, survival? So what we saw was that the group of patients that do the worst are the idiopathic pulmonary fibrosis patients. And that has been replicated in numerous studies all around the world. And it's an accepted, unfortunate reality that that clinical diagnosis of IPF has the worst survival in terms of interstitial lung disease. What was very interesting, though, was that we saw that our patients who had that autoimmune feel, that suggestive form of a CTD-ILD, they actually did even better than the connective tissue disease, the more definite form. So we got to be careful because of small numbers and retrospective and single center, but what it I think highlights to clinicians is that identifying these patients that appear to have an autoimmune basis to their interstitial lung disease looks like it has significance with respect to their physiologic trends. Those with autoimmune disease did better and improved survival.
Is there a hypothesis why patients with CTD-ILD have improved survival as compared to just ILD alone?
Sure, lots of hypotheses. I don't think we have a really good understanding as of yet. Having an autoimmune background, perhaps more responsive to therapy, perhaps having less likely fibrotic patterns. So an autoimmune patient maybe has more non-specific interstitial pneumonia, more cellular patterns like organizing pneumonia, maybe a different age group, younger, more female predominant. But the reality is I think there are some commonalities that are there just, irrespective of underlying cause. More fibrosis, more likely to be trouble. More of a UIP pattern, that pattern of usual interstitial pneumonia, more likely to be more difficult. Worsening lung function, irregardless of whether, or irrespective rather, of whether it's autoimmune or not autoimmune, worse lung function, worse outcome.
What are the main takeaways that you and your fellow hope people take from this poster?
I think what we're trying to highlight is that there exists a group of patients who do not fit neatly into categories. Presently, we know definite connective tissue disease ILD as a group does better than idiopathic pulmonary fibrosis. What we wanted to look at was, how about those patients who are not definite CTD, who have that autoimmune flavor? And I think what we show is that, A, these patients are there. We can find them. And they're not isolated to Denver, they're in almost any program around the world. And the second is that these patients seem to behave a lot more like the true connective tissue disease patient than rather the idiopathics. And so I think this is a group of patients we're going to want to study longitudinally.
Thank you, Doctor, for sharing your news with us.
Thanks for having me.